If you have a great idea, but you're in the forest, and no one's there to hear it, it really doesn't matter.
So for 13, 14 years, I've been doing this kind of assessment. And I created these diagnostic testing targets and these treatment vectograms. And, you know, I disengage financials in these products because you lose credibility if that's your purpose. Clinical practice, that's what I do. So 3 years ago, I started to get involved with also writing this paper, because I just couldn't see that as I verbalized this to people, that the next year they were asking me, oh, so I had to sit down and take this time to look back at 60 years of work and study what was out there. I didn't do it for a journal. Who's going to publish 9 case histories? In fact, I heard Leonard Cohen, a poet, great songwriter, and I'm the man. He said, you know, I wasn't really happy till I realized it couldn't change the world. Well, that's not how I feel right now. I did all this to be here now in this place with all of you. So welcome to my forest. So let's rock and roll. Thank you. So the key thing was that I started to look at measurements that were inside Panums area. So let me explain that briefly. The classic Vergence measures that we've all done, the difference between those is very simple, because it's exactly the same as what we've always done. The methodology of how we do these tests is identical, except the differences are the target used and the endpoint, the criteria. So when we do classic Vergence measures, I'm using divergence, convergence, base-in, base-out prism to take the demand to the point where you start to notice blur and then double, and then you recover single and clear. When you go to diplopia, you're measuring the limits outside Panums area. But when you measure associated Vergence measures, you're measuring inside Panums area. You are still single. You are not double. But you develop a fixation disparity, an offset. So perhaps I can just briefly explain how I would do this and explain this to a 5-year-old. So the first thing I try to tell them is, I show them the target, and I say, you see these arrows? This is straight. If they start to slide, that's what I want to know. If they start sliding at all. Now, then I take my fingers and said, is that sliding or straight? And if he should say that's straight, I say, no, that's sliding. Now what's that? He says, that's straight. Now what's that? That's sliding. I then proceed to take the Polaroid and put it over the target. And I say, you see how this starts to fade on one side? If it fades when I'm shutting down, just tell me if it starts to fade. And then I hold up the target and I say, this is straight. And then I put the Polaroids on and I begin the testing. So I just want to give you a sense of methodology of what I'm asking for an endpoint. Now, the near point of convergence has the same issue, because the endpoint is when is the stress enough to cause the blur and double and recovery single clear. The endpoint of the near point fixation disparity is when do you start manifesting the slip, the fixation disparity? When do you recover that? Now, to see the target, you're looking at a target that's like this, and the top target is the fused target, and the bottom represents the left eye, and the top represents what the right eye is seeing, and the common center. So these are polarized. Now, I think what's important, too, to understand, if I go back to this, is that the classic vergence measures incorporate the accommodative convergence, the fusional vergence. But as I get into the disparity, it's more like a disparity vergence, where the near point of convergence is more the proximal. The big thing here is the common fusion lock, the central common fusion lock. So when we look here, we're basically looking at orientation, which is the alignment of those fixation disparity arrows. And what's interesting there is they parallel these nonius lines, this vernier acuity, this hypersensitive acuity. It's very hyperperceptual. It's very sensitive. And I think that's the reason why very young children can pick up this disparity very easily, which has been very helpful to measure a reliable, more sensitive test in young children. The central lock, the E, was what was really, I felt, critical. You see, all the targets that we've used before would often use a dot in the center if they even used a central lock. Well, I didn't feel that the blur is that sensitive to a dot. I felt we needed a better identification target. The circle surrounding represented a perceptual symmetry, a figure that you could aid the active alignment with the arrows, because it's very easy to see the top and bottom of that circle so that the E wasn't kind of an asymmetric figure. It supported alignment. Now here's the interesting thing. So many of the targets being used a peripheral fusion lock. When you start using a peripheral fusion lock, it becomes much more associated to dissociated for you. And that was the critical issue, because my goal was to create a central lock, incorporate an accommodative target that was sensitive to blur, because all through those 60 years of looking at the targets, it was clear from Ogle on that it was the central targets that would aid a measure that was more sensitive to the active reading. And I clearly biased what I'm presenting today toward binocular vision in the active reading, or focal processing. Now, let me explain this. You'll see from the title that we're creating a binocular state of confusion when disparity manifests inside Panums area. It's the argument versus the breakup. And let me give you a little language way of understanding that. It's like a relationship. Some people will argue and argue and argue and just never break up. And other of these patients and data will show that the minute there's a tight relationship, because the previous one is more of a loose relationship. The tight relationship is the argument is very close to the breakup. Very fragile. It doesn't take very much argument to cause the breakup. It's when the burden of fusion demand is placed on this binocular vision system and it's just too great to compensate for. So binocular disruption manifested by this fixation disparity represents a confusion in the visual system. The confusion is where those symptoms lie, I feel. It's not the break. And then there's this fight or flight response in dealing with that stress. So when we're dealing with this confusion state of a manifested disparity, you are actually looking at one word, but your eyes are not aiming in the same spot. Now, when it comes back to this fight or flight response to stress, you can take two individuals with the identical visual problem, and they will handle it different. One will tend to manifest those symptoms and fight response and hone in and use their finger and display the blur and display the headaches. And the other one, like what I had, will just kind of go on, turn alpha, space out, read the whole thing, lose all their comprehension. They're so busy trying to keep their eyes on the page, they can't concentrate on what they're reading. Now, the other thing that I find fascinating is that most of what I hear in measures is measured based on the break. I didn't feel the break was the most important finding. It was the recovery. Because you're self-actuating in a way the knowledge I'm teaching them to see how do they recover. Now, maybe how did I know that the recovery, even though I felt that way, was the more sensitive measure to depict what was going on in the patient? I asked my patients, what do you think? I'm doing this paper. They feel part of it. I said, what do you think? You think the break is more reflective of what's going on or the recovery? The recovery. I mean, you're manifesting a break in disparity. What do you do about it? So the recovery reflects that behavioral response to that stress. So here's something interesting. You see, to me, if you have an argument, one of the partners might take the lead and start in the argument. But the recoveries are bilateral. Both sides, both individuals have to come together to make them come together. So the recovery itself is a bilateral, binocular phenomena. It isn't unilaterally generated. I believe it's a binocular effort to recover. Now, the big thing here is that I measure this vergence recovery range. So I'm measuring the spread, the range of the base in recovery to the base out recovery. And not only is it the spread or the distribution, but it's the distribution has a center of symmetry. Where is that center of symmetry to that spread? It is the center of the symmetry that has the fastest prism adaptation time. And when the person is first starting to manifest these things, there is a clear, in dysfunction, binocular dysfunction, there is a clear major drop-off in this capacity to have quick prism adaptation time. So when I do these measures, I am measuring the relationship between the recovery of diplopia and clarity and the recovery of alignment through disparity and clarity. And so one is, and you'll see this indicated, one I relate to as the vergence recovery range, and the other I refer to as the associated vergence recovery range. Now, a short prism adaptation time is the nature of the measure. It is the essence of the point. You see, fixation vergence, disparity vergence is very rapid, within a second. So one is that we are measuring amplitude. the power of that response. We're measuring the break. We're measuring the recovery. And it's important to understand that we want to control the effective blur. So we're maintaining a recovery of alignment and clarity. Very important tool, and we'll talk about why later. Now, I will tell you that this post-treatment, you can manifest a very wide range so that the argument takes a lot to happen. And when you're going to get to that point, post-treatment, the argument is very close to the recovery. The argument is very close to the double. And so, and here's the interesting thing. When you're getting this initial response, which I'll talk about, and you might find they break and they can't recover this, and I started to get them post-treatment, or at least further into treatment, the question is the disparity manifesting and then recovering along the way to get to the limits? So I asked my patient, tell me something. Do you see the lines shifting and coming back and shifting and coming back? Or do they appear to be aligned all the way out to the limit? And they say, no. It stays aligned until I reach my limit. Another important characteristics of the fact that prism adaptation time, short prism adaptation time, manifests itself throughout that measure until they hit the limit. Now, one of the things that was interesting is the relationship between what I am measuring and the dyspyrometer. I have that dyspyrometer. You can't even get it by James Sheedy anymore, and I have that dyspyrometer. But here's what's interesting. Look where identification is. It's in the periphery. Do you have clarity in the periphery? Now, not only does it manifest to look more like the dissociative phoria, but your periphery is not clear. And orientation is in the center. And it does move toward more of the dissociative phoria. I wanted identification in the center. So it mimics, it biases the target toward the act of reading. When we do the dyspyrometer, the prism adaptation time is allowed to be up to 15 seconds. When we use the central lock, the prism adaptation time is much quicker, much more rapid, and you get a lot less variability in the literature, and you get a lot better repeatability. Just like you might manifest a little variation in the dissociated phoria. So, I don't know if Steinman's in the office, thank you, in the audience, but thank you very much. Steinman had done this piece of showing a fixation disparity curve. Now, if you were to take a look, you're adding prism. I don't think this is working again. I'll need this by the end for my case studies for sure, but whatever's making this not working. But if you take a look, pardon me? Oh yeah, that's good, thank you. If you look here, you're seeing about 10 base in prism to 10 base out prism manifest this flat portion of the fixation disparity curve. So in other words, the prism did not start to induce a shift in disparity until they got out to 10 base out and 10 base in. And where is the center of symmetry? Right at 0. So it gives you a sense of the disparity curve. I wanted to measure the lion's share of the measure. This takes a long time. I wanted to measure that relationship of this portion of the disparity curve And I wanted to measure the distribution and the center of symmetry. And that is the relative measure that relates to the associated divergence measure. So here we are. What are some of these relationships or differences? The associated divergence measure uses a central identification fusion lock with an accommodative target, while the dyspyrometer has a peripheral fusion lock. The associated divergence recovery has a very short prism adaptation time. 1-2 seconds. I look for the hesitation. I start to manifest the disparity. They say it's slipping, and I say it's still slipping, and they have this look like it's not back yet. Then actually, once I know that it's not, I increase the prism demand and then decrease the recovery. The dyspyrometer has a much longer prism adaptation time, up to 15 seconds. I wanted to understand the measure would have a reflection of the minimal time and energy that should be allocated to realigning your eyes inside Panums area while reading. Quick and sensitive. Because it takes such a short time to administer, it's not only easy to do, it's easy to repeat. The associated divergence measures mean being rapid and repeatable is a reflection of one of the most important findings we have, stamina. Now, when you find you have a good associated divergence range, recovery range, it parallels a wide, flat range in the fixation disparity curve. And the associated divergence recovery range pays equal respect and measure of the center of asymmetry as does the fixation disparity curve. It's a spread and the way it's shifted. What's interesting is the way it's shifted reflects in the associated divergence recovery range reflects the associated phoria. Now, probably the most important thing that I think reflects on these measures is the nature of either a loose relationship between the classic divergence measure range, recovery range, and the associated recovery range. Because the measure of diplopia endpoint can totally underestimate symptomatic patients. Here's the tricky part. When I have patients that have a loose relationship, a wide classic recovery range, and have a very tight, a very narrow spread of the associated divergence range, these are the patients that are the least complaining of the symptoms they manifest because they're the most apt to sit there and turn on alpha and get real global while they're reading. So the very ones that show this loose relationship are the very ones that are least apt to respond to saying they get this. It's like you ask them, do you get a lot of symptoms when you read? Do you notice anything about it? No. Of course, I don't read. So I think the important thing is this relationship, a loose relationship, can actually have us have the impression that the patient does not have a binocular dysfunction, and yet they can have a very difficult problem with binocular vision. But it isn't reflected until the associated divergence measure uncovers it. There is more binocular confusion without a stated diplopia. The tight relationship shows that the spread is much closer to the spread of the associative divergence measure. And when I ask these patients, they classically look at me, or the parents look at me, and they handle the stress like an all or none response. They're either working hard or they're not there. So it's interesting about the way this reflects on the behavioral style of the way they handle the stress with a quantitative measure. Again, when I look at this all or none thing, how do I see the consistency? I turn to the patient's mother. I say, how do they handle the stress? So you get a lot of information by making them a team member in the thinking. Post-treatment, there is a tight relationship between the associated divergence measures and the classic divergence measures. But the range is wide. Wide range. A lot of stress to create an argument. And that same stress is very close, within a few prism diopters of when they get into diplopia. And you'll see this in these case histories I'll get a chance to show you. This is case number 1. And although I'll show you the case histories at the end, you can always turn to case 1 to get a reflection of it, but I wanted to show you a tight initial associative divergence range recovery and classic divergence range recovery. All of my case studies are convergence insufficiency. All of them. In the initial finding, the recovery range of the classic divergence measure to diplopia was 6 base in recovery and 0 base out. So the entire recovery range was 6. This describes the spread, the power, the amplitude, but does not describe the center of its hemorrhage. You can see that in the measure, but it does not describe the center of center. What we're telling you, when you look at that number 6, it represents the spread of power. But the associated divergence recovery was 1. It actually manifested as a 2 recovery base in and a -1 recovery base out. And there was good agreement in this measure of the CI vulnerability of base out. The ratio was more like 6 to 1. If you look down and see the final, you'll see that the divergence measure of this classic divergence measure was a range of 42. The limits were 16 base in and 26 base out. And the associated divergence recovery range was 15 base in and 20 base out. So we've now got a relationship between 42 and 35. Now, I'm just going to introduce a taste of the near point of convergence versus the near point of fixation disparity. You see, the near point of convergence was an 8 break, a 16 recovery single clear. And when done a second time to get a sense of stamina, it was 12 over 15. The initial disparity measure of near point of convergence, the near point of fixation disparity, was at 39 inches. So they are sitting there watching and reading single, but their eyes are offset. A state of confusion. Let's look at the difference between that and the greatest vulnerability I see, a loose initial relationship. Case 2. Here you're going to find near findings that show, and later on I'll give you far findings as well on some of these cases. Here you will see an initial divergence recovery range of 42 prism. The base in break recovery, was 14. The base out recovery was 28, a total of 42 prism diopters as a power spread. There was a 0 range in the associated divergence measure. Anything off of ortho-induced fixation disparity that could not be compensated for within a second or touch more. So this is the nature of what I'm afraid of. Those patients that are that are manifesting a serious binocular vision problem. The data does not reflect that as a regular vergence measure. The patient is more diffuse about their nature of dealing with the stress, and as a result, not climbing the wall with headaches, not climbing the wall with stress, more of a flight response to stress. Alpha goes on. You start to get more global, more peripheral. And this is where I stood for years until my last year of optometry school. I could read it all and not read a word I just read. It was boring. I'd have to hone in, word by word, sit in a cubicle, cover my ears, force myself to read. It was survival, and I was not always in the mood. It's like running a race with 10-pound gym shoes on and not knowing. It's always been that way. The exam, 2.8 years later, the vergence recovery range was at a range of 43 prism, 18 base in recovery, 25 base out recovery, and the associated vergence range was 43. 19 base in recovery, 24 base out recovery. A 43 over 43 ratio as compared to a 42 over 0. The initial near point of convergence was 8 over 10 inches. Still receded. But the near point of fixation disparity manifested a disparity at 14 inches and recovered at 16 inches. You see, I had a responsibility not to change the initial way that I ran regular vergence ranges. I didn't want to modify the test too quickly because I needed to compare what I've done for 40 years in comparison to this new way of manifesting more of a threshold measure of binocular disruption. Now, classically, for sure, in almost all cases, in convergence insufficiency, the near point of fixation disparity lies outside the near point of convergence in the initial assessment. Now, here's what's interesting. The binocular diagnostic profile. These are just thoughts along the way. First of all, I'm measuring alignment and I'm incorporating an accommodative lock. Now I can investigate the positive relative accommodative function and the negative accommodative function in an associated way. Now, there are a few things that are interesting about this. One, I get a chance to get accommodation and orientation to talk more sensitively to each other. So now I start to get into minus stimulate positive accommodation as if they were over-accommodating to bring their eyes in alignment, and they manifested disparity. So I said, okay, take a look here. And I take the disparity target. I'm using the bigger one here. And I say, well, tell me where it starts to line up. And I move it in, and they say, here. You see, I believe that they are moving the target in to deal with the fact that they've over-accommodated, it's dragged their disparity into ESO, and they're trying to decrease confusion. So they're actually manifesting, pulling in, just the same way that the studies that I've seen, I think it was with Sheedy, in computer work, when you manifest an exo disparity where they want to move back, to place their posture to decrease that confusion inside Panums area. Now, here's another interesting thing. It just kept going on and on. Paradoxical binocular profiles. 25 to 30% of your patients with CI manifest an ESO fixation disparity at FAR that is not always at all obvious through the regular vergence measures. So they are actually posturing themselves with often an exofixation disparity, or certainly fragile convergence response to prism. And yet at distance, they're in an eso posture. Very important finding relative to clinical thinking, clinical intervention. How are we handling that? Where's the middle? When you look at vertical binocular dysfunction, there is very little slop in the system between the associated divergence measure and the classic divergence measure. Therein lies a place that if you were defining prism for a vertical, you would get pretty close relationship between saying how much prism base up versus base down, and where would I get the prism that would neutralize the best compensatory prism to align them. So this tight relationship exists in the vertical meridian. It does not exist necessarily in the horizontal meridian. Now, let's talk about methodology. First of all, there's a lot of ways to do this. My favorite way to approach this, having gone through the explanation of what I'm considering to be the endpoint, and just so we understand, I created very succinct endpoints: clarity, alignment, blur. This is not to say that you can't induce a convergence or divergence vergence measure and say, what are you experiencing? So I don't want you to think that just because I've created this succinct endpoint, then I might not also say, what are you experiencing? What are you feeling as I bring this about? What is happening? Leaving an open endpoint. So I just want to mention that because with due respect. But in order to do this, I had to start with a very succinct endpoint. So I will classically hold this up and use a Risley prism. Because one of the most important things to me is to have them in free space. Because I cannot see their response to stress behind the phoropter. But this is not to say that I can't put this inside the phoropter and create bilateral Risleys. So in lies the big question. What's the story about holding up a Risley prism in front of one eye? So, as a clinician and an investigator, I had to raise doubt. So what I started doing is doing it both on the right and the left. I would do divergence first on the right eye, and I put the Risley prism then on the left eye and do divergence, and then I go to the right eye and do convergence, then I go to the left eye and do convergence, and I would make these measures. And except for the issue of stamina, I was not really seeing a difference. But this was of concern. Now, I will tell you that when I turned to Ann, my therapist for over 29 years, she said, oh, I wondered that too. So when I was using the night light and I would make these measures as part of my auxiliary testing, she says, I would try it the other way too, and I never saw a difference. I said, oh, good. So that to me was very interesting. And in the literature, it was clearly indicated by Carter in the 1960s that the site dominance was not equal to the fact that the directionalization, this ability to start to directionalize against the prism, that the right eye and the left eye were equal in terms of their vision of disparity. Now, in an amblyopic eye, they may be different, of course. But certainly, within the context of the cases we're talking about now, binocular dysfunctions, we didn't see a difference. But it needed to be investigated. See, the hardest part is that you always remember those things that satisfy your hypothesis. And the art of clinical thinking is to challenge yourself to say, is that really true? Because every discovery of something that goes against your thought either takes you down or leads you to new discoveries. So the big thing was that it was a smooth divergence range. It was a gradual increase in the prism demand. And when I start to increase the prism, I started saying, well, how fast am I moving this prism? It was about maybe 5 prism, in about a second's time, gradually increasing demand, just to give you a feel for how I administer these tests. Now, I bring attention to clarity and alignment. As I'm going up, is it still clear? Another tool for arousal. Because as they manifest near the edge of their fusion range, they start to have this response to stress, this fight or flight response to stress. So my ability to cue up clarity allows me to reinitiate a state of arousal and attention and to alignment. The break and then the recovery, allowing only about 1 or 2 seconds, but maybe 1 second, a little over. And you can see it. If you're watching them, you can see that they're not recovering of adaptation. It's a hesitancy beyond the 1 second. The center of symmetry is important. Now, here's something important. You see, blur is clearly a big issue. Because if you allow blur to occur, you can spread the horizontal range of Panums area. You can spread it. Now, you trade off clarity for alignment. You can intentionally or unintentionally allow that blur to occur to look better. I think that's why large print makes it easier. A little bit of blur is not going to affect larger print. And you can maintain minimal confusion inside Panums area. It's when the print gets smaller that the clarity becomes more critical to identification. And when that occurs, you don't have the gap. And it's the disruption in Panums area that is where the symptoms surface. Remember, I'm measuring recovery, and even though I know that the right and the left eye show an equal division of disparity, the recovery is a bilateral phenomenon. It's the central lock that's so critical to this test. And it's the disparity divergence measured is so quick. And it's amazing how the blur can modulate the Panums area into a wider range. Now here's what's also interesting. You want to talk about modulating the size of Panums area? When you start reading about temporal changes. Temporal changes. When they start adding temporal changes and the increased temporal rate within these tests, Panums area shrinks. Shrinks. It can go from an oval to more of a circle. Remember, this is not being affected in the vertical meridian. From an oval to a circle. Shrinks with temporal changes, transient changes. Why, yeah, because Panums area is really constructed for these central processing issues. And temporal starts to manifest out there in the transient system. Because what's involved with these measures is the slow-moving, sustained part of the divergence system, and even the sustained part of the transient system. And it's the flip divergence measures that are more in the fast-moving divergence systems. So this temporal modulation, I thought, isn't that interesting? It shrinks. It's saying something. Did I hear what it was saying? It's measuring more of the sustained function. required in reading of the more focal system, the more sustained system of the fast-moving virgin system, the more sustained system. So it's dominant for those acts. Now, let's talk about the near point of fixation disparity and the near point of convergence. You know, the near point of convergence is very interesting in that the target started out with a light, very often, and then start throwing on red, green. And then, when we started using an accommodated target Lederer, Ken Kifrida did studies early on where it clearly increased the reliability and repeatability of the measure. Again, a central lock. Again, we take this target, and I'm using the large one to make it easier, and we're bringing it in until a fixation disparity manifests that cannot be recovered within a second or hesitation beyond that. Is it still sliding? Okay, now and I'll say, on the way in, I'll say, is the letter E clear? Yes. Tell me when the arrows start to slide. It's sliding. Is it still sliding? Yeah. And then I start to bring it back until they recover, and then I ask, is it clear and aligned? And they say yes. You know, it's so fast that the repeatability is important. As a clinician, I don't have the time for a lot of reasons, but I don't have the attention of the patient. And it allows me to do more assessment in a very quick, effective way with a hypersensitive target. In the Rouse study, it was interesting, in 97, 93.8% of ODs used the near point of convergence as their primary diagnostic determination of a convergence insufficiency. What about the near point of fixation disparity? First of all, the target uses that small diagnostic target, small diagnostic fixation disparity cross, with a central lock, with an accommodative target. And I use a little reminder to create both arousal and awareness of clarity to enhance the measure's definition. I take them till the break when a fixation disparity starts to manifest, and I bring them back until it's recovery aligned and clear. Again, prism adaptation time is that 1 second or a touch more. I like that hesitation time. Watch their face. Watch their face. I'll talk about this again. Watch how they're handling that. Now, I start about 50 inches out. And I ask them, is it lined up, or are you manifesting, a shift? Are the arrows shifting? And that's primarily for convergence efficiency, and then I start moving it in. Now, should I put that at 50 inches and they say there is a disparity? I move it out until they recover. And then I bring it back in until they break. And then I move it out and recover it, because I'm always getting a chance to measure the stamina breakdown. Because without stamina, it's great if you only read one page. But without measuring stamina, you don't have a taste for what's happening in the visual system. 1 lap is great. Can you run 10? Not with convergence excess. With convergence excess, they say it's clear as I'm close, and I bring it back until they manifest an ESO disparity. And then very often I throw them out there and I say, what's happening far? It's off. I said, how interesting. When you look at a ball out there, your eyes aren't manifesting, your eyes aren't looking at the same position. And very often it is predictable of swinging early or swinging late. And I thought the comment yesterday about Panums area spread was interesting. That's got me going. It's the things that you don't know that instill the next bounce board of thought. That's the fascinating thing. This 40 years of this, and it continues to go on with the same enthusiasm, the same discovery, but I'm not interested in doing things that are just academic. I'm a clinician, so I'm constantly searching for things that are consistent within the patient's response, symptomology, what I'm seeing, performance. Now, when we look at the near point of fixation disparity and prism adaptation response, there is no question that the near point of fixation disparity is much more sensitive to binocular dysfunction. And actually, the near point of convergence can be totally normal with an abnormal near point of fixation disparity. What's more interesting, what's as interesting, is the nature of what happens along the way. The brake recoveries to the maximum load. That adaptation of the effort to create this prism adaptation effort to recover alignment. This is not the way this is post-treatment. And repeating the measure is an essential component. And it would not be true if I was doing fixation disparity curves. Excuse me, they are powerful measures, disparity curves. When your base out is down, you have more of a type 3 disparity curve. When your base in is down, you have more of a type 2 fixation disparity curve. But I wanted to know the centerpiece, the 90%er. What's the most interesting to me is the response at the edge of that fusion limit, the style. Watch them. I will have patients that will try to fight it. And that is the way they'll handle therapy, to a point. Sometimes until they hit the wall. But their initial response is to fight it. Oh, I figured out what you're doing, I'll fight it. And I'll have some turn to me and say, get out of my face. Because people have this confusion inside Panums area, and many of them get angry. You see, 55% of the patients that I see are often above grade level in reading, but are smart perfectionists. You want to talk about visual binocular dysfunctions are huge emotional issues. Huge emotional issues. And when you want to do things perfect, and you're bright, and it's not working, when you fail, when you miss the ball, and the other kids laugh in baseball, you are not playing baseball again. When you get hit with the ball, that's it. When you see chapter books with smaller print starts to break up, that is not for you. And you will use all your power. How do kids, I know kids young are brilliant because they have PhDs in avoidance behaviors. They work you. They push your buttons. They don't push the stranger button. They push the buttons of mom because she's home. And he'll read a page until he starts breaking up and rattling, and she takes over because she feels it, and she reads a page. And he'll read a page until he starts breaking up at the end of the thing, misreading little words, not big words, little words. That's the difference. They can decode the big words. They miss the little words, the look-alike words, the periods, the endings, the turn on alpha. They're spacing out what they're reading. They're not getting comprehension. And they work it. And when I turn to that child and say, yeah, pretty nice, huh? If you can, do you try to get mom to read the whole thing to me? And they inevitably smile at me and say, yeah, boy, you work her pretty good, don't you? And they just can't help themselves. They just can't. Yeah, it's cool. You know. And it's that humor that's the centerpiece of my clinical work. I do not communicate with the parents. I clearly indicate to that child I work for them. 90% of what I do is communicate with the child. If they get it, if they get what I'm saying, and it's the best thing about having a binocular problem that I had. It was a bear. But the best thing about having a binocular problem is they feel me. It was a killer. 2 years in high school, I'd blow it off. And then I worked so hard because I was scared I did great. 2 years in college, I'd blow it off. Postponed my homework to the very end. Then I had so much homework to do that I was so tired because I postponed it, I have an anxiety fit about how I'm going to get through it. They look at me like they get it. I said, you can't go through school like I did. It's a physical coordination problem. It's like riding a bike. Once you get the coordination, it's automatic. You've got it forever. You don't need to do therapy anymore. You just need to know how to use it and check it every so often, see if you feel confident. It's that response at the edge of their fusion limit, their style. To me, that's the centerpiece of communication. That's the centerpiece of empathy. That's the centerpiece of understanding that he sees that somebody finally is asking the right questions. Normals. You see, I'll take them and usually find they'll get about 3-4 inches, 3-inch break and a 4-inch, 5-inch recovery on the near point of convergence. And about the normal would be about there for the near point of fixation disparity. If I take a normal, and I might even take a myope, which is like equal refractive error, like -2s, and just take off their glasses when I do it, and you're just throw out the accommodative issue. And I start adding base in and base out to where it manifests the disparity, I can usually get them to 12 prism base in and 16 prism base out. How do I know? Vigilance. Testing everyone. Vigilance. Everyone. It's so quick. Discovery. But what I do is, on divergence with 12 prism base in limit, I stop about 8 and say, hey, is it still aligned? Is it still clear? To recapture arousal and attention as they get near their limits. And I do the same thing for the base out at about 12. So I stop for a second and I recalibrate their attentional arousal to make sure they're on target. Now, just remember, when you start to see asymmetries in the fixation disparity, where the centerpiece is a base in or base out, what I do is I hold it up and they say I'm manifesting a disparity. Let's say it's a low base out. So I take the Risley and I move toward the point where they're neutral. That represents their associated aporia. And it's from that point that I start moving into divergence and convergence measures. I neutralize their disparity associated aporia. Then I go from there to divergence and convergence. It's vigilance. It's finding something that's quick and sensitive and continuing to do it and to do it. Treatment. Driving the visual system to the divergence limit represents the point at which the system can no longer compensate. Ogle described patients treated for binocular dysfunctions were associated with long, flat fixation disparity curves, wide divergence ranges, and reduced asthenopia. 60 years. 60 years. They all said the central accommodative target makes it more like reading. 60 years. It was a lot of fun going through the literature and finding where my flaws were. And learning more, but finding how consistent the literature was, what I was doing now. Treatment. Establish the recovery fusion range, span that. Span the recovery range of the associated divergence ranges and the classic divergence ranges. Establish a more normal center of symmetry. And that is where you have a sensitive measure of the accommodative binocular alignment relationship, so I can add plus in the system and increase the divergence recovery, and that decreases the convergence recovery. That's where the sensitive measure gives me a much more sensitive measure where clarity, accommodation can talk to alignment in a more sensitive threshold way. The characteristics of normal binocular function, amplitude, power, all these measurements, the measurements in my case histories, they're measurements of power amplitude. They do not measure flexibility. One must incorporate flexibility, but remember, just in the recent September AOA journal, that vergence measures work on fast vergence systems. Flexibility is important. Stamina is important. understanding concept. You know, they need to understand what they're doing. Now, excuse me, point taken. We work with a lot of children who are not at the level cognitively or age. We're in treatment. They can give us these measures. They can understand concepts. So what we do is we provide experiences. We integrate those experiences. But in these cases, what I'm presenting today, it is very important they understand what the strategies are. Because how do I get to integration? How do I overload them and not give them a place where they know how to fight out of that? How abusive. And when I see a child who doesn't get concept, who doesn't understand what they're doing, especially when convergence comes up so high and now they can't diverge, and I put stress on them, I'm taking them right back to where they were in the beginning. They don't know how to counter me. Cruel. I don't look to them and say, you're not getting it. I look to myself and say, I'm not teaching you well enough. So the problem is not to take the easy route, but to ask myself, what am I doing wrong? And you have no idea when I say that to a child how they look at me. I de-emphasize them, and I tell them, it's me. Convergence distributes attention more focally, more positive accommodation, more sustained parvo-dominant functions of central vision, more focal identification. Divergence distributes attention more to the periphery, toward orientation, negative accommodation, transient magno-dominant functions. It contributes to posture and movement and orientation. Reducing confusion inside Panums area. Where are we at the end? Easily resolved fixation disparity for a significant amount of divergence and convergence prism or lens demand with a short prism adaptation time, sustained over time, establishes the minimal binocular confusion. This reflects as enhanced binocular efficiency and stamina. These gains result in improved comfort, reduced or eliminated visual symptoms of stress while reading. Measures made outside Panums area do not have the sensitivity of measures made inside Panums area. Associated measures of binocular dysfunction are more sensitive in identifying symptomatic patients. Working at the edge of the divergence range. The very way you see them look at the edge is the same way they encounter stress during reading. If I can induce, I tell them, that same fatigue and stress and nausea you're feeling at this moment, you better believe it's not the book, because I don't need a book to do it. When they can connect those dots and I reduce the stress there, they see the connection. I tell them I'm making them a scientist. Understanding concepts and strategies. Automaticity is reflected in a smooth acceptance of this increasing prismvergence demand, stress, where fixation disparity does not manifest until you get to the end of that maximum fusion load or range. Integration is supported if the patient understands and can apply these learned concepts to withstand the additional demands such as movement, balance, cognitive overload, divided attention. This presents a foundation for the development of automaticity. This is what constitutes long-term change that sustains a lifetime. Questions. Oh, is it shifting? Is it still off or lined up? Do either the arrows fade out? Suppression. What is it that's moving? No, it's not the arrows. Look, I take the polarizer. It's not the arrows. What's moving? All trying to get them to realize that they're in control. Does it stay in the same place? Is it moving further away? Is it moving closer? Can you change it? Can you make it move closer? Can you make it move further apart? Nothing like not only getting a patient to do well, but asking to make it worse. Another point of view to learn from a different stance, a different point of view. What are your strategies? How are you doing? This is the fixation disparity targeted mirror. Central fusion lock, vernier type acuity for hypersensitive measures, a circle around the E to give it symmetry so that the E itself doesn't throw them off. This is the target I use at far, not just at far. See, if the patient starts suppressing, I shake the target to get more transient. If I shake the target, they start to break suppression. If I shake the target, they don't say, I pull that far target in and I enlarge the target. So I use the bigger target. Doesn't mean I throw out the test. I got another way to test those ranges and indicate that I went to a more global, bigger target in order to decrease the suppression. I test these things at far. The gem. You see, in creating the gem, there was the rope quoit, right? And the rope quoit does it by shading. That's how I remember sitting at Salk Institute, and here's Ramachandran talking about stereopsis, and shading gives you a sense of stereopsis. Perspective. Lines are more man-made perspective. Shading is more nature. How do I get that? My art. I'm always dealing with the conflicts of black and white compared to color. They don't go together. How do you make them work together? I take man-made lines, edges, perspective, compared to shapes, shading, nature. It's a great place to create discussion, thought, arousal, respect for your patient's think tank. Here also, same idea, shading versus perspective. It's a place to think. It's the thinking that engages the patient in what they're doing and how they're doing. Now, the vectograms move on. I put the fixation disparity cross smack in the center of the gem. Why? Because I wanted them on the same z-axis. I wanted the gem and the two-dimensional target to talk to each other. I wanted the gem to teach them where to look to achieve the cross in alignment. You see, if they look at the cross and it's off and they're doing divergence, and I engage them in the periphery of saying, where is the gem floating? Look where the gem is floating, and the arrows will follow. This is how you find where it is. So it's very important not to have just this central two-dimensional thing in one aspect and not have the peripheral gem floating not be used as a tool for learning. So whether it's convergence here and then the arrows line up, the purpose was to get them to talk to each other. I thought what was interesting too was when I presented the gem in perspective, Gefrida did this wonderful article in Leonardo, an art magazine, in 2002 that talked, is one eye better than two when viewing pictorial art? See, I have a lot of kids who draw, who do art. It's a great place to engage them. What he said was, if you're looking at a two-dimensional piece of art and you really want to get it even popping more, cover an eye. You got the three-dimensional neural system in sculpture working, and you got this two-dimensional representation of the illusion of 3D. You want to cut out the conflict? Cover an eye. What a great place to get interaction. What a great place to have respect. You may hear this again later. But I work for that kid and I tell him, I work for you. I don't work for the parents. I want them to know that I respect them, so I can gauge their thinking in this kind of thinking. Why did I move and take out the central lock? My overconvergers, they can't stop going for the identification. I said the lock is out here. The lock is out here. So I said, what happens if I knock out the central lock? And I make the gem the peripheral lock. I'm trying to get them to get it, even under stress, when they tend to go back. It was a great way to try to take these rough ones that are over-convergers, or the ones that really develop such great convergence in a short period of time that now the divergence is so hard. It's the balance. And then the variable just cross only. Why? Integration. I didn't want them to use the gem as a crutch. I didn't want them to use the gem as a crutch, because you don't have something teaching you something else while you're reading. I wanted to pull that out and say, well, can you just do it with this? And if they learn to use the gem as a tool, cute little devils, I just knock it out. And I say, can you do it here? Can you transfer what you've learned? This was the sequence of events that we developed over time. Now, let's get into case reports. Concrete clinical thinking over time. You're going to get a tight relationship, 3 loose relationships, another tight relationship, 2 cases that travel over 9 years of data post-treatment, or 8 years post-treatment. And then 2 cases of an ophthalmologist optometrist, one with doing nothing but pencil push-ups, and one doing vision therapy. Now, here we go. You see, here we got in this initial one case, the one I showed you earlier, you'll see that the near point of convergence, the initial time was at 8/16 inches. The repeat measure, 12/15 inches. Within the first progress report, 6 sessions later, 4/6 inches. But the near point of fixation disparity, as I indicated before, 39 inches over 39 inches. Again, within first 6 sessions, proximal divergence kicks in, 4 inches over 6 inches. Repeatability, stamina, no. We assume there's still vulnerability. Is it automatic? No. I assume they can just generate what I taught them. Now, how do we read this? And that's why I put these in your folder so you can study them later. How do you read this? Here represents the classic divergence ranges in this color. Here's the associated divergence ranges, and here's the case where I use plus, so you can see the effect of plus on that system. I set this up to have you look first at the beginning and then at the end. So the most dramatic issues represent the differences. And here's a tight relationship. Again, divergence ranges were 6 prism spread. And here you can see the base out, nothing. 0 recovery. Base in, 6 recovery. 6. What was it for the associated divergence ranges? 1, displaced into -1. By the end, what we had was a spread of 33 prism for the regular divergence ranges, and then 35 prism for the associated ranges. Here's where I put it in this to give you a quick guide. Initial, 6/1, tight relationship, final, 33/35. And here's what happened when I added plus. Here I only did the divergence, the effect of the plus, and here I measured most with an associated range, the effect of plus shifting that range, decreasing symptoms, and balancing the center of symmetry. Just for interest, here's FAR. The regular divergence range was 2/2, 4 for the regular divergence range, alternate suppression on the associated divergence range. Here's what's interesting. Here's the spread in between. I figured you don't even have to look at the numbers. Just see if you can see. My purpose was to get a quick visual. You can see the changes going through. Watch how here there's still a vulnerability in the associated divergence range, which is not as present in the regular divergence range. But watch the spreads. Watch the spreads. Case 2, loose relationship. Loose relationship. Near point of convergence, 8 inches over 10 inches. Within the first progress report, 3/3 inches. Near point of fixation disparity, near point of fixation disparity breaking at 14 inches, recovery at 16. First progress report, 4/5 inches. Now here's where it gets interesting. Here's the divergence range. 42 prism diopter spread. 0. Any kind of stress was inducing a disparity and confusion. What happens at the end? And these are the last two. This is the progress report at 2.5 years, 2.2 years. This is 2.8 years. The spread, 43 over 43. So here you see it. 42 is to 0, loose relationship, and 43 over 43 for the final. What was it at distance? The regular divergence range, base out was recovery at 7, base in was 4, total 11, 0 range under associated divergence range. Here you got the middle. See the spread coming up? Here it comes. Still showing this loose relationship. Look at this spread, comes down a little bit. You know, you got a little variability on 1 or 2 prism, big deal. It tells you the essence of it. Get down to here. At the end, you can just see the flow of data. And I was hoping not to get you number oriented, but even though it has a lot of stuff on there, to make it just more visible, jamming down that piece. Here's a loose relationship in case 3. Case 3, and these are all CI, because how do we know? Take a look at that. Look at the asymmetry in convergence versus divergence recovery. Of course, would you have picked it up if you saw this 48 prism diopter spread? You're good. You're good to go. Near point of convergence shows definitely receded. It was 14 over 18 inches. Second time, 14 over 18 inches. You notice the break came in a little, like he's fighting a little harder. Like, you see their style. I mean, you see them, they fight. I said, whoa, boy, do you know how to fight? What happens when you hit the wall? Is that over? They know what I'm talking about. You know, see, they work all day long in school so hard to press that by the time they come home and it's mother, they blow out on her. Aren't moms great? I had the greatest mom in the world. A lot of us had the greatest moms in the world. And you know what? Still feel guilt. Because they're there. But when they come home, it's a safe haven. It's a comfort zone. And they work it. They're brilliant at it. Here, within the first progress report, these go to 4 over 6. But look, there was exo disparity at all distances. All distances. And when you look over here, first progress report, it didn't come up all the way. It came to 14 over 16 inches. It took by the second progress report 13 sessions to come into 3 over 4 inches. It took a little while, but remember, I recognize the vulnerability, repeatability. These are power measures. They don't, again, reflect flexibility, often stamina, unless I repeat it, like I have in some of this. Look at the spread here, a 48 prism, 24 over 24. Look at the asymmetry spread of base out associated for you. Look at the range. It's 6. Total fusion range is 6 prism diopter recoveries, 8 base in, -2 base out, and it just sits right there. Look at it at the end. 52 over 48. Here we are summarizing. Initial, 48 over 6, a loose relationship. Final, 52 over 45. Here's it at far. Initial regular fusion range, 12. Associated fusion range, 1. Oops. Here, we've got another loose relationship. Near point of convergence is 3 over 5 inches. Near point of fixation disparity is 15 over 16 inches, done twice. recovery pretty good. But when you drop down to the beginning of the recovery range, you see the difference of 30 prism diopter spread, very balanced, center of symmetry around ortho, but the disparity was offset. Three range. Final, we got a spread of 36 over 34. At distance, same kind of loose spread. 17 vergence range and a 4 vergence range under associated conditions. Take a look at that spread evolving. This stuff is so interesting. Case 5. Now, from here on in, I just put them all in there. The only reason I took those first 4 cases and left out the in-betweens was to get you a quicker visual. You know, it's a lot of data until you get a sense of what it looks like. That's why I put the case reports in your piece. That's why I put the article in there. So here we got a near point of convergence of 17 over 16 inches. Or is that 10? Yeah, 10 inches. Repeat. 5 sessions later, comes into 3 over 4 inches. 6 over 6 inches by the second progress report. The near point of fixation disparity. 16 over 20 inches, repeated 35 inches over 35 inches. It just receded. You have no idea what it's like when the parent's sitting there and you start to see they're getting a disparity out here, and I say, you know, if they're breaking up here, what are they doing at 16 inches where they're reading? They're looking at every word and their eyes are offset, and they're not double. They have no idea. Confusion inside Panums area. Here you see a much tighter relationship in the data. Here you've got a 12 prism range. Look at that associate range and how offset it is. If this kid doesn't hit late, I don't know what. He sees the ball further away than it really is. If this is present at near, which is this, and again, that was just an idea if that was at far. If he sees that at near, he's not moving in closer. You see the spread of the changes at the first progress report, at the second progress report. Look at that third progress report, 26 session later, 8 months later, 52 prism diopter range, 49 prism diopter range in associated measures. Center of symmetry is good. And that represents tight. Why did I put 2 tight relationships and 3 loose? Because I'm scared of missing loose relationships that give me a false read. Now we've got 2 cases, data 9 years out. The first thing you need to look at, both, again, all convergence deficiency, and you can read it from the way it looks. If you look here, this is the initial assessment. 22 prism diopter range. These are both looser relationships. 22 prism diopter range at near. 0 range skewed at a -1 recovery. Look at the spread over 9 years of retention. I don't know if Dr. Grisham's in the audience. There he is. He looks at me last year when I showed him this, and he says, how much therapy after that first year? Post-treatment. And I said, none. None. If it's truly integrated and automatized, if they understand concept, there are 2 things, 2 qualities that will assure you that these gains obtained last a lifetime. One is automaticity. If we don't take them to the edge of that range and try to break them up, if we don't try to get them moving and they can't hold it, if I don't try to have a math problem figured out and they still move, if I don't try to divide their attention, if I don't try to overload them, if I can't turn to them and say, I'm going to get you, and they look at me and smile and say, try it. You don't have them. Try me. It doesn't mean there's a limit. They know there's a limit. They have mastery. They have mastery. So what do I do with them over 9 years? What do I recommend? I recommend that they check out classically the GEM PL with a cross and the gem in there, which I give them. I want them to have it a lifetime, college, high school, before ACTs. And I say, look, it's like shooting baskets. It's motor memory. You don't forget. You shoot a few, you got the motor memory back. Two things I want. One, they have a quantitative way of assessing that they have command of the system and they haven't lost anything. I don't like it when I say, how far can you go into divergence into the letters, and the kid looks at his mom. I just don't like that. I don't want mom to know they have no reference. I want them to understand what their limits are so that they can pull that thing out periodically before an achievement test a week ahead, measure their fusion ranges, and know I'm good. Two reasons. One, it quantifies control, establishes an understanding of what they've learned, and gives them a sense of emotional security. Because the emotional things with these problems are huge. Huge. We are losing people every day because they have... It's the misdiagnosis that becomes so distressful. It's the dumb, stupid, lazy, bored. You see, there's two ways that I see in my office when I wrote up this piece I give to my patients that describes a lot about vision and perception and processing and motor. You know, it's this sense that they have a sense of control on their visual system. And they think dumb, stupid, lazy, or bored. We take ourselves down. We're all more than we think we are. All more than we think we are. But I put something in there that I was going to take out. And I sat before a mother and she said, don't take it out. That's my son. And that was, I don't have a problem. I'm fine. I'm fine. I don't have a problem. You know, they learn coping mechanisms. And I said, you don't have a problem. Your eyes aren't just working together. You don't have a problem. I mean, we can get rid of that. It's not like some problems where you have paresis, motor limits, sensory adaptations and strabismus where I can make it better and compensate for the rest. That's not, I can get rid of that part. Besides, it's not the problems you have, it's the way you deal with it anyhow. I've had to go through things with my ninja poles over the last few years, and there's probably nobody that's on the water kayaking and sailing and sculling as much as I'm out there. All these people have no problems. They're not out there. Who's got the problem? So we have kids who have learning disabilities. They have great self-esteem. It's all centered, everything. It's self-esteem issues. I put them in control. I connect the dots. I get them to get it, and I make sure they know that they're in control of that problem. So what happens in those 9 years? Pull it out. Check it out every so often. Do it before an achievement test. Give yourself that security blanket. Take it to college with you. And P.S. So I had one patient, treated her years ago. She's in college. She calls me. She says, I started breaking up visually. I started having trouble. She says, I pulled out the vectogram. I spent about 3 days with it. I booked an appointment for a progress report Christmas to come in. She was fine. What was my first question? Are you getting enough sleep? College student. See, I said, if it breaks up, you got to ask yourself if you've done a good job. If the patient's done a good job. You really have to ask yourself, what about the external things that induce the breakup in your visual system? If you're diabetic, your sugar's out of whack, that visual system's going to break down. You got allergies, it's driving you out. You don't get sleep. It's not like you don't have the same learning and control over your visual system. It's just that all the systems are down, and your visual system just is a reflection of that. Take a look at case 2, and you see the same thing. So you're basically seeing a 22 range in regular Virgins range, where the real range was only about 4 prism. Although I must say that the associated Fourier was right at ortho. But I hope you can see, what was, excuse me, that's the one part I guess about using the zeros. The touch. But here at the bottom, you can see this relationship between the initial 22/4 and the final of 42/38. And if you watch the spread, give or take a little latitude, they've all got it. And none of them did more therapy. And it's an important parameter. And remember, if they're breaking down, if I find a vulnerability, it's great. The child having the doctor turn to him and think, maybe I didn't teach you well enough. It throws them off balance, takes the heat off, lets them think with me. It's like when you're under stress in a relationship, you get so busy arguing with each other, you don't even talk about the issue. And so part of it is to deload that kid. This isn't this kid's fault. This is how he's had to adapt to the dysfunction. And without giving them command, and you see, what we are doing is we are giving them an island of representation of every other struggle they will have in their life. If you don't think dealing with these visual problems like this is stressful, this is really a stressful thing to break through on. Because they associate the endpoint, the edge of that range, that feeling in their gut. I can't do this, I can't do this. They're inner talking. You can hear them, they're not saying a word, and you hear them saying, I can't do this, I can't do this, I can't do this, I can't do this. And that inner talk becomes a representation of every other struggle. This is what I find fascinating. If I can get them through this, if they can get them through this, they can do anything. So it isn't just getting rid of the visual problem. It's making them see who they really are. The ones that don't transfer. Data is not what it's about. And decreasing the symptoms is not just what it's about. The key element is that they've learned to never read for pleasure, but to only read under pressure. How do you break that barrier? How do you break the barrier of always being poor at hand-eye coordination in sports? Where you don't want to go out and do it again. I say, go out, no one around, take dad, take mom, throw the ball in the backyard, start out where you can do it, back off, start to see you're better. I don't care if you play baseball. I just want you to know you're better. So if you ever decide you want to do it, you know you're better. It's not their age. It's not their age. These kids at 6 are magnificent at adaptive behavior and playing everybody. They manipulated the world to control the adults to keep them out of doing what they don't want to do. And they raise the stakes. And then you're so busy with those strategies that who gets them to read? And it works. So the idea is, I had this one guy, I'm a sailor. I had this guy, he's a sailor, he's a teenager. I said, I got a good book for you. There's a book called Sailing Away, and there were like 30 of the best short stories you ever saw in your life. You could see an end. You could see the light at the end of the tunnel. You could jam on 15 pages, jam on 20. The adults. It's like I had one kid say as he's recovering, he says, oh my God, I had to read 20 minutes. I read the 20 minutes, and then I don't have to stop. It's like, read another 20 minutes. I don't have to stop. On the other hand, very interesting clinical situation. The mother home educates. She said before he could read 10 minutes, that was it. Now I got him reading an hour and 10 minutes. 1 hour and 15 minutes. Do you think the rest of the therapy you think the rest of the therapy will let them go longer? So I look over at the kid. I said, I had this problem. I said, before you could only read 10 minutes, and now she's got you sitting down for an hour and 10 minutes. Are you getting a little restless? I mean, getting a little claustrophobia after a while. I mean, if you never sat down and read that long, you're in there, you're going, enough. Get me out in space, So these strategies, these communications, give them an accomplishment of learning, an accomplishment of understanding. Respect their capacity. Kids are very smart, very early. Respect them, and they'll follow you. Now we've got pencil push-ups for 2 years. A psychiatrist's child. The next two cases both have headaches and double vision as just two of the symptoms. Pencil push-ups for 2 years. High performance smart. Comes back after 2 years. And the doctor says, you're going to need to do this the rest of your life. Now, I'll tell you something. It makes me weep to think of what that felt like. If you'll notice, great near point of convergence. Great near point of fixation disparity. No fusion ranges. No vergence recovery ranges. No associated vergence recovery ranges. Nothing. Here you're going to see more distance data, okay? Because I figured I'll show you some distance data on a couple cases. So here we see an arrow. Found it. And here we've got 13 range with low base outs. Again, all convergence efficiencies. The convergence insufficiency articles that hit were great, because people are trying to figure out what's going on, and they see a reliable study. Excuse me for those that have done that study and move on. Very, very important. 12 sessions don't mean integration. 12 sessions don't mean you're done. But huge impact. Okay, so we've got a pretty tight relationship, 13/9. We get into treating, and we see here, we've got an alternate cover test at 25 prism diopter exit for you. The foria can stay that way. You do an alternate sustained cover test, and you can still see those dissociative forias. They've just got so much coordination, it doesn't manifest itself. I mean, it's coordination of the system defies the dissociative foria. Associative forias are more sensitive, but the idea is the foria is just a tendency. The coordination overrides that, trumps it. Here, you see at the end, huge, this child was motivated. Like 7.5. Several years above her reading level. You get all these kids 3-4 years above their reading level, freaking. Vergence recovery range 47, associated recovery range 46. Take a look at FAR. A regular vergence range of 11 prism diopters. Associated vergence range shows an ESO disparity. See that on the other side? 1 point in space. Base in -1, base out 2. This is a paradoxical. CI at near, ESO disparity at far. Within the first 13 sessions, at far, we see a range of 22 and 10 at far. Oops. Then, 21st progress report, basin was only recorded for far. And see pretty good 7 prism diopter range. And then again, the associated vergence range at the end at far was 7 prism base in and up to 27 prism base out without a disparity. And she was motivated. 2 years. And saying you're going to need to do this the rest of your life. because of no knowledge. I would like to think they're not doing it on purpose. They just don't get it. I would like to think that way. They just don't get it. The bias is killing people. Here, optometric therapy. I have the luxury of evaluating this kid, and then the child in the therapy program elsewhere. Oops. Near point of convergence initially, 20 over 22 inches. Again, headaches, double vision, high level of an emotional stressed young man. Brilliant. 18 and at near point of fixation disparity, exo fixation disparity everywhere. Everywhere. Far, near, sorry. I guess this is the product not having a pointer, huh? Exo, maybe it's my touch. Exo fixation disparity everywhere. By post-treatment of 18 sessions or so, the near point of convergence was now 16 over 20 inches, 22 inches, and the disparity started at 30 inches and recovered at 35 inches. 16 sessions later, now we put it down as neuromuscular reeducation. I mean, it's a semantic issue about how we look at that integration and adding movement, balance, and integration and understanding. And 6 over 6 inches, both the near point of convergence and the near point of fixation disparity. So once they finished that previous treatment, within 16 sessions. It is interesting that one of the first things I did was I took a target with a letter and I moved it in to that 16-inch spot, and it was double. I said, what do you do about it? I don't know. I said, why don't you try this? Look at the tip of that letter, see if you can make it clear. He says, now it's one. Strategies, understanding, on the way to automaticity. What is your strategy? At the end, they should be blindsided, and I throw something at them. I said, what are you doing? Diverging, converging? What are you doing? Figure it out. And it's watching them figure it out that gives you the greatest insight. Okay, so now I take a look at the divergence ranges. Here we take a look. And in the yellow, at near, initial evaluation, the range on a divergence recovery range at near was 1. Can't miss it. Tight fusion range. Definite visual problem, no matter how you look at it. Recovery range of -2 for base out. Associated divergence range, 11 over -11. I mean, they had associated foreheads. Really, really off. 16, 17, 18 sessions later, and this other treatment program, divergence range was 6. The associated divergence range was 6, and there were still minus recoveries. Still minus recoveries. Okay, here's first progress report after 6 sessions on the return. I'm lucky that he had the courage to re-engage himself in treatment once again. Belief systems. Would you? Or would you just say, it doesn't work? Emotional risk. Watch the range just build. But watch in that first progress report at 6 sessions how the base out recovery at near was still far lower, but it did not at all reflect as a vulnerability in the divergence ranges that are classically done. And at the end, the final was 41 prism diopter spread regarding the divergence range, this regular divergence range, and a 43 diopter spread in the associated range. So it went from a spread of 6-1, 16 sessions later, 17, whatever it was, comes back, 6/0, post-treatment, 43/41. Look at how it was at FAR. This was not a paradoxical ESO at FAR and convergence deficiency here. He was divergent exo disparity exo at distance as well. So at FAR, we find an initial 4-range recovery on regular versions, classic versions, a 1-range recovery with displacement of center of symmetry on the associative vergence range. Vision therapy, 18 sessions later, a vergence recovery range of 2, associative vergence range of 0, and watch how they unwind. Watch how they unwind. Why would I not? Why would I not just do associated vergence ranges? Why would I just not only do the associated near point of convergence? Because the gestalt of associated ranges and classic vergence ranges are bigger than the parts. That the relationship between those two tests provides insight that you would not have had. It wasn't just because I had to compare what I did to what I had been doing for 40 years. I'll give it. It's what I was seeing was creating a picture of that child within just these measures. Do I use these measures only? No. I see the entire gestalt of that full workup, and it talks to me. You see, my initial assessments, even when I do perceptual assessment, is as much reading between the lines as reading on the line. The kid that comes through the perceptual workup, I've done the auxiliary, and he's getting tired, and I run the TVPS, and he's at a 10% level, a 20% level, a 15% level on all of it. And then I pull out 2- and 3-dimensional block designs, and he nails it like it was a drop in it was nothing. The qualitative test gave you a feeling that it trumped the standardized test. So I turn to the child and I say, the consultation, I say, what? You're a little tired and blew it off? And he looks at me and goes, yeah. Can you believe the honesty in these kids? Yeah. I said, is that what happens during achievement tests? He says, yeah. Those tests become distorted. It gives you a sense of who they are. They need someone who not only recognizes the profile, but respects who they are. And I must tell you, using humor, humor is a big one. And an in-staff I gave, and I had to bring the staff in to do this. I take a 7-year-old kid. Let's say one time I'll talk amblyopia. Takes a 7-year-old kid, he's got amblyopia, and I want to do some patching in. Even if it's a little bit of patching. I don't do heavy patching if I can help it with activity, see. And he doesn't want to do it. He just doesn't want to do it. Hates it. Fighting with tooth and nail. I look at him and I say, let me ask you a question. I've got your 6-year-old kid in here. It's your kid. Would you blow off the patch? In a millisecond, he goes. There's something about maturity of a young child who feels a sense of dependency that is so primitively ingrained that they just, within a millisecond, go, no. And you will get a few of them who will look at you and say, yeah, well, let them do whatever they want. Because they know what they're answering. And they want to fall into that trap. I look at them and say, you stinker. I had 2 kids come in, and they're young. and they're getting fusion, and they're doing pretty good. And we hand them the gem PO. And the father brings them in, and he's not the one usually working with. And I find out they go home, and they tell their mother they only have to do the conversions. I said, you stinkers! Because they want to do what they do well. It's because of not just doing what they do well, but when they work at the limit of their vulnerabilities, they create the same associated symptomology that they get that has always taken them down to the ground. And they don't think about what it is they're doing. They feel it, they sense it, they associate it, and it takes them down to the core. And so they avoid those stresses. If I can connect the dots on those, and they get it, and they see I'm inducing it without the nature of the book is just another reflection of it, I can get them. Once they've got it, they're in control for years. So I just would say this to you. I want to thank you. It's been an honor to present this material to you today. Thank you very much.